Kia ora koutou. Welcome to tonight's Goodfellow Unit webinar on immune-related adverse events associated with immune checkpoint inhibitors, the new age of immunotherapy. My name is Danusha Amalang, Specialist GP, and tonight we have Gareth Rivalland with us. Gareth is a medical oncologist specialising in cutaneous and thoracic malignancies. He is the lead of the melanoma team at Auckland Hospital and medical director at Harbour Cancer and Wellness Centre. His focus is bringing cutting-edge treatments to New Zealanders, having been the local principal investigator on a number of groundbreaking regional and global studies. This webinar is sponsored by an unrestricted educational grant from Pharmac. The content was developed independently by the Goodfellow Unit and our expert speaker. I will now hand over to Gareth. Thank you.
Thanks, Nuna. Good evening, everyone. Welcome to this presentation. Hopefully you find it useful. I realize that in the oncology world, we do live in a bit of our own little space, as I was saying, an ivory tower. And so this topic that we'll talk about today is something that I would deal with every day and be thinking about every day, but I realize that it's not going to be something that everyone has a lot of experience with. So what I hope to do today is just walk us through our thinking around immunotherapy, potential side effects, and we can discuss afterwards if I've missed anything or if there are specific questions that we haven't quite touched on. So let me just share my presentation here. And I want to thank you for your very kind introduction. It's taken away everything I was going to say about myself. So now I have nothing to fill the gap before the talk. So, over the last probably 15 years, the treatment of many cancers has changed significantly. And immunotherapy has really been groundbreaking in the two areas that I specialize in, which is melanoma and other cutaneous malignancies and lung cancers. And so this is a world that has been changing rapidly and has implications both positively and negatively for our patients. So tonight I'd like to speak about our immune-related adverse events, this new age of immunotherapy. And I thought we'd start with a gentle introduction, explaining how we think about the immune system in cancer, why it's important for us to think about immunotherapy now. And then I have a couple of illustrative cases to walk us through specific examples, and hopefully they'll be able to open up some of the discussion about other side effects, and then we can come to the conclusion and take any questions. So let's begin 25 years ago. This is the landmark paper by Hanahan and Weinberg called The Hallmarks of Cancer. And at the turn of the century, they highlighted 6 particular characteristics that were typical of cancer cells. And really, I illustrate these 6 because you'll notice that even 25 years ago, the immune system did not make it onto the list. So we've got resisting cell death, sustained proliferative signaling, so i.e. growth signals. They forget how to die, they can invade. These are all typical features of cancer cells. But in fact, the recognition of the importance of the immune system in the development and the subsequent escape from the immune system was really only highlighted in the early 2000s. And you'll notice here that by the time they republished this paper in 2011, they'd added some extra elements to here. And the one we're most interested in is this avoiding immune destruction. So one of the key elements that cancers have to achieve in order for them to go from normal cell to expanding, growing, and metastasizing cancer is they have to find a way around the immune system. And actually, this idea is not a new idea. This is one that was first proposed over a century ago. This is William Coley in 1906, who found, 1908, who found that in a young patient with a sarcoma who developed erysipelas, that person's cancer regressed. So he thought that streptococci or some immune-related event related to this infection had caused the reduction in the sarcoma. And so he went about mixing this Coley's toxin, which was a mixture of streptococci and serratia bacteria species, thinking that it may help cause regression. But it took a long, long time for his idea to to find legs and be proven in the lab. And it was really only in the 1990s and 2000 that people began to understand the interaction between the immune system and cancer cells. One of the key understandings was that, in fact, there were two main elements happening here. People have been trying to vaccinate against cancer since the 1980s without much success. But here we go. It was the recognition of these immune checkpoints that really unlocked our modern immunotherapy. What are immune checkpoints? As with everything in our body, this hopefully we'll take everyone back to med school here and refresh some memories. So, as with everything in the body, there are sort of promoting signaling and there's negative signaling. And these immune checkpoints act as negative signals on immune responses, if you like to think of it like this. There are two main ones that we use here, and I'll just explain the one on the right first, this PD-1, PD-L1 interaction. What we have here is a tumor in green, and it's presenting a neoantigen, so some new protein or carbohydrate structure that is abnormal in the cancer cell. And this T cell is coming along and recognizing that neoantigen and saying, hey, that's not one of ours, we need to attack. But the cancer puts out a second protein, in this case PD-L1, which binds to this PD-1, and that shuts that T effector cell off. So essentially what's happening in this situation is the cancer is actively shutting down the T cell response to it and thereby allowing it to escape. This is a key understanding. A Japanese researcher in the early 2000s discovered this protein interaction, and this really unlocked a lot of understanding about immune checkpoints. I have to say the first one developed and brought into the clinic was this slightly more confusing one, which is this checkpoint of CTLA4, and that stands for cytotoxic T lymphocyte antigen 4. And really the principle here is that in the tertiary lymphoid structures, so in this case we've got a lymph node there, as your immune system winds up and you want it to, say, attack a chest infection or a cellulitis, that immune response is accelerating. And CTLA4 is expressed on these T cells as they're self-regulating and switching off. And so it's a negative regulator of the immune response. So as soon as these presenting cells start to express CTLA4, it will switch off immune responses. This makes sense if you've got an infection. You want to keep having an immune response against a treated, or at least an infection that your immune system has cleared. But in cancer, what this does is it subdues an immune response too early, if you like. And by blocking CTLA4, by inhibiting this, you can allow the immune system to keep activating and to run a bit further. So the way I describe that for patients is it's a bit like cutting the brakes on the immune system. It's not specific to the tumor, but it allows it to run a bit further. And the current immunotherapies that we'll discuss today that we're using in the clinic, these are monoclonal antibodies. So we can see them here. They're designed to come along and bind to either this CTLA4, cutting the brakes, or to this PD-1, PD-L1 interaction. And by blocking this interaction, the way I describe it for people is a bit like unmasking the cancer. It allows the immune system to see it again. It's no longer inhibited, and so it can attack if the cancer cells are recognized as being foreign. And so essentially what we're doing with these monoclonal antibodies is allowing the body's own immune response to reactivate against the tumor and hopefully shrink it or get rid of it. And these are the common immune checkpoint inhibitors that are used. So ipilimumab is the one that inhibits CTLA4, and Opdivo or nivolumab and Keytruda or pembrolizumab are the PD-1 inhibitors that were developed 15 years ago and have been used for many, many different cancers. So why is this important now in New Zealand? Well, it's really this. In the last 6 months, Pharmac has had some extra funding, and there's been a decision to widen access to immunotherapy. In September last year, they included 6 other types of cancers, including triple-negative breast cancer, head and neck cancer, bladder cancer, some bowel cancers, and refractory Hodgkin lymphoma. So the use of these treatments is going to broaden from the two areas that have been using it for a while, which is melanoma and lung cancers. And in fact, they're talking about increasing the funding even beyond this. So I think we're going to see more and more patients across New Zealand have access and therefore exposure to these medications and the risk of these side effects. So I thought, why don't we start with some cases so that we can use our clinical brains to help us walk through how we might think about side effects in this situation. So why don't we talk about Mr. MG? He's a gentleman who we met some years ago, 73-year-old Iranian man who was a retired mechanical engineer, fairly innocuous background with ischemic heart disease, and presented in Tehran with excessive tearing of his right eye. And he had a very dramatic presentation of a lacrimal duct melanoma. So you can see it here pushing through the and moving his eye off to the right-hand side of his, it's pushing through the orbit here. And if we have a look at his scans, what we can see in the left panel, this is a PET scan. So all of these white areas, barring the bladder and the infusion, are areas of melanoma where they're taking up the radioactively labeled glucose. You can see he's got widespread metastatic disease, liver, lungs, up here in the orbit. If we look at the central CT scan, this coronal section here, we can see blood vessels, but, innumerable lung metastases, sort of the more you look for them, you can just see dots spotted everywhere. And those are all metastatic melanoma deposits spread there, obviously, through hematogenous metastasis. And we can see here this large lesion in the right orbit displacing and proptosing his right eye. And so, this is obviously a dramatic presentation. So in this situation, what we would recommend with such widespread disease is the combination of a PD-1 inhibitor, in this case nivolumab, and the CTLA-4 inhibitor ipilimumab. They give us higher response rates. But when you're combining immune checkpoints, there is a higher risk of side effects. And so when he initially started, these drugs weren't even funded. So this was, he was accessing this through private funding in a private clinic. He began in December 2016. And by March 2017, he was admitted with fatigue, headache, nausea, vomiting, and dizziness. And obviously these sound like fairly nondescript symptoms, but further investigation, so blood tests revealed that his sodium was 122, slightly elevated ALT. And as we can see here, he had an MRI with his pituitary gland enhancing in a way that it wouldn't normally. And so this gentleman, in fact, developed hypophysitis. And we can see that he's not only has a low TSH, suggesting that he's not getting enough thyroid stimulating hormone, but a low T4. And so this is pointing to a central cause, not to mention he had low cortisol and low testosterone. And this low cortisol would be the reason for his hyponatremia. But despite the fact that he had very innocuous sounding, symptoms, it could have been a virus, it could have been something else. Actually, what was generating those symptoms in his case was a significant toxicity from our immune therapy. And this will be a theme as we run through. It's changing our way of thinking of what the likely side effects are in people who are undergoing active therapy. So what side effects could we think about? I mean, these are sort of pointing out just the top half of the body, but literally any part of the body could become inflamed. So anything that's susceptible to de novo autoimmune disease is susceptible to autoimmune toxicity from immunotherapy, because essentially what we're doing is asking the immune system to recognize a neoantigen and attack a tumor, but those proteins could be fairly similar to something on another part of the body, and by inhibiting these immune checkpoints, it inhibits the body's own ability to use those to stop an autoimmune effect. And so literally any part of the body could become inflamed, from a uveitis to, the saliva glands giving a dry mouth. The skin is very common. We have the endocrinopathies that we've just seen right throughout the body. And so when we look in some of these original trials that were guiding us in terms of understanding what side effects we might see, we could see that quite commonly rash, pruritus, vitiligo. You can see that skin toxicity and fatigue were the two most common, and that remains true even now. So when I speak to people about side effects, I say, you're not going to have the severe toxicity you might see with a chemotherapy. You won't lose your hair, but you may feel a bit of fatigue. So it might steal the top 5 or 10% of your energy levels more commonly, or you could have a skin rash or itch without rash or some variation on that. So those two are the most common, fatigue and skin-related toxicity. But you'll notice that there are others here: diarrhea, nausea, vomiting, abdominal pain. These aren't specifically autoimmune necessarily, although of course rash and they can be. But really, it's the breadth of side effects that are useful for us to think about. And it is literally from head to toe. Any potential side effect, we have to be thinking about an immune-related response here. So as you can see, this is a slide from a publication 2019, just documenting potential symptoms, shortness of breath, fatigue, chills, diarrhea, abdominal pain. I mean, essentially what this table does is list out any potential symptom that a person might have for any reason. And I think really the way that I think about side effects for people on immune therapy is any new symptom that someone has, the first filter we have to run that through is this an autoimmune complication of immunotherapy? And once we're happy that it either doesn't fit, or we've tested for that, or we've admitted them and made sure it's not that, then we get to go on to our standard differential diagnosis. So, a person who presents with chest pain, may be having an MI, but we need to think about, do they have pericarditis or a myocarditis or some other variation on an inflammatory side effect first, so that there's a discipline in thinking, okay, the normal rules do not necessarily apply for these people. And that's true for a diarrhea. It's more likely to be a colitis than it is whatever takeaway they had, the night before. So if there's one rule that I could leave you with, it's just this rule, which is any new symptom, we should have the discipline of checking and thinking about, could this be an autoimmune complication? Why is this? Why do we have this breadth of side effects? Well, there are many potential mechanisms that we think about and that are being investigated now as causes that could generate these potential symptoms. So we could have increased T cell activity. So, the immune system recognizes a melanoma, but as a side effect of that, also attacks normal melanin cells and they develop a vitiligo. Or another case here, it might be against a self-antigen, like in a myocarditis, we see that. Potentially with a colitis, it increases inflammatory cytokines, predominantly causing a pattern of symptoms that's not unlike inflammatory bowel disease, Crohn's or other variants of that. We may see that there are existing autoantibodies. So the endocrinopathies are quite classic for this. So you might have antibodies already directed at the thyroid, and that introduction of the checkpoint inhibitor immunotherapy allows the immune system to actually attack the thyroid, and you develop a thyroiditis and then hypothyroidism. The other thing that's sort of interesting, which is related to our gentleman, is that actually some tissues might express some of these proteins as well. And so the pituitary gland actually expresses the CTLA4 on the cells. And so that might actually induce complement-mediated destruction directly related to the treatment. So it's not that the immune system is necessarily attacking those cells. It's actually the monoclonal antibodies binding, inducing an antibody-dependent cellular cytotoxicity against the pituitary gland. So there are a number of potential mechanisms that we need to think about. If we come back to our gentleman here, once he was diagnosed with the hypophysitis, we replaced his hormones. But if we do find an endocrinopathy like that, we don't tend to stop the treatments, because those organs become underactive, and we replace as we would normally, and then we keep going with therapy. And as he came through sort of March into April, he developed a mild hepatitis. At that point, we were pretty cautious with his care. And so we paused his treatment and treated him with a 6-week course of corticosteroids, in this case, prednisone. And that would be our standard approach to immunotherapy toxicity. We stop the treatment and we give prednisone. And depending on the severity, if it's moderately severe, we would be looking at 1 milligram per kilogram prednisone and looking at a 6-week wean of steroids. That's a sort of frame that we would think about. And when we're talking about moderate intensity, the clinical trials grade side effects on a 4-point scale. I guess there's a 5th point there, but that's, we don't often get to the point number 5. So 1 is mild, 2 moderate, 3 severe. So severe is a broad term, but it might be enough for someone to land in hospital. So if they had a colitis, say, and they were having a lot of diarrhea, well, you might actually take them to hospital to give them intravenous fluids or intravenous steroids. And then a grade 4 side effect is life-threatening. So we'll see some of these terms as we come through this next bit of information. What do we do for this side effect? You can see here in the European Society for Medical Oncology guidelines, they advise different treatments depending on, as we were saying, the grading. So he had a mild grade 2 side effect, so they suggest here withhold the therapy, as we said, avoid other medications, and then we would use steroids, so corticosteroids at 1 milligram per kilogram per day, which is exactly what we did for this gentleman. And his hepatitis, as you saw on the prior slide, that improved over the subsequent weeks. And in fact, we were able to get him back to treatment. One of the things that's interesting over the past decade or so is with the success, people are looking at targeting other points because, the tumors might not only be using PD-L1, PD-1, there are a number of other potential immune checkpoints. And so recently we've had trials targeting LAG3, OX40, TIM3, TIGIT. And so there are many new treatments that come along that can actually, with benefit, they also increase the risks of side effects. And so what we can see here, just to give you a feel for, the difference that we might see. If we think about, there's another medication called relatlimab, which targets LAG3. In this situation, what we're seeing is a bit more hypothyroidism, thyroiditis. Again, we can see that with our standard PD-1s. But if we look at ipilimumab, as we were saying, that the one that targets CTLA-4, we see 1.6% of people have significant hypophysitis, whereas it's 0.4 for our standard PD-1 inhibitors. So this difference in thinking about which medication the person's on and what their risk is helpful just in terms of increasing our suspicion for anything that might be happening. So a gentleman who's on nivolumab and ipilimumab turns up with a headache, immediately we're thinking, okay, we need to check the pituitary gland. We need to do those blood tests. We need to think about an MRI. Obviously, this gets more complicated. I won't dwell on the slide, but as we learn more, there are certain things about people that might put them at risk of side effects. We're noticing, say, with people who have type 1 diabetes induced with immunotherapy is very rare, but they may have an underlying autoimmune predisposition to this. So there are a number of things that we still need to learn to understand how we protect people. One of the big questions that people will ask us is, okay, I've had this side effect, can I go back onto treatment? And the interesting thing about these side effects is maybe they don't need to go back onto treatment. And what we've got here is a survival curve published 2017. And in the blue line, there are people who had an autoimmune side effect and stopped treatment. So these are people with melanoma, I should say. And then the yellow line are people who did not stop treatment. So they had their side effect and they carried on. And what you can see is that those lines are not too different. So actually what we think may be happening there is once you've generated this significant immune response, you may not need to carry on with treatment. In fact, because you may be getting the immune activation that we need to see. So this is really useful for us in the clinic because what it means is that if someone has a side effect, what we should do is we should stop it, we should treat it well, and we should treat it with steroids without any fear of us reducing the anti-cancer effect. So in some ways, that was quite a relief for us as we were working through the clinical trials. A decade ago, we were all worried that corticosteroids would reduce the anti-cancer response. In fact, it doesn't seem to do that. It allows us to thread the needle of being able to control their cancer and their immune system without a deleterious effect on either. And they're, speaking again to what might be happening in an underlying fashion for these, and this concept of, what does it mean if I get a side effect? There is some tissue specificity to side effects. So, here's a gentleman with melanoma, and he's developed vitiligo. About 8% of people with melanoma will develop vitiligo. And again, it makes sense. We're asking the immune system to recognize a melanoma cell, and it gets confused and attacks people's melanin cells. We virtually never see vitiligo in people with lung cancer. And so, it's one of those side effects that really gives us a clue as to what's happening with the immune system. And in fact, it is also prognostic. So if you develop vitiligo, it's a side effect that's most associated with an improvement in survival. And we can just see here, this little line in green, people are doing better, and those people had vitiligo versus other side effects. So this tissue specificity has an interesting element to it. Similarly, with pneumonitis, people with lung cancer, it's much more frequent. So in this left-hand panel here, we can see people with melanoma treated in this trial, Keynote 006. They had very low rates of pneumonitis, 0.4, 1.8% there. Whereas in the squamous non-small cell lung cancer trial, Keynote 407, we can see 6.5% had pneumonitis. So, quite a significant difference there, 15 times the rate, if you like, of a tissue-specific side effect. So, if someone with lung cancer comes in with a new cough, in general, and they're on immune therapy, obviously, what we're thinking is, okay, we're not going to give you antibiotics. What we are going to do is if that cough isn't any better, we're going to bring you in and do a CT scan for you, in 24 or 48 hours, because we need to make sure that you're not in that 6% of people who's generating a pneumonitis. So this is that golden rule again. Any new symptom, we need to think about, could this be an autoimmune complication before we immediately go to our, common potential causes. Why are we doing all of this to people? So just to bring us back to what's the benefit. This is one of the original trials, this Checkmate 067. This publication has been updated subsequently. But what we can see here is that in stage 4 melanoma, the green line is people who had ipilimumab and nivolumab, like our gentleman. And what we're seeing here is that 52% of people are still alive at 5 years with this treatment. And this used to be when we only had chemotherapy, people's average life expectancy was 9 months. And we've just had updated data where it looks like cure rates are up around 50% for people getting combination immunotherapy in stage 4 disease. So that really is a big change for us over time. Obviously, there's a 50% of people that we still want to do better for, but this is why, we have to trade off the risks that we've spoken about with these benefits. Okay, why don't we move on to case 2? So this is another gentleman with melanoma, 82-year-old man. And I think the first thing we would say is that the side effects are not necessarily age dependent. So you all think I'm mad saying this, but the oldest person that we've treated with immunotherapy at Auckland Hospital is 101. And she had in-transit melanoma. So just to allow it to grow would have given her a huge number of issues. So that's the reason for us doing it in her case. But, a gentleman who's well and who's 82, that's a reasonably common scenario we see. His background was in November 2019, resection of a right jaw melanoma. For what it's worth, it was staged to PT2B, sort of moderate risk stage 2. This is in 2013. And in 2019, he had a rapidly enlarging chest wall lesion. And at that stage, we were looking at clinical trials for this situation, but he wasn't that interested. Then in January 2020, had a leg nodule develop, and this was recurrent melanoma. The PET-CT, we can see at least 4 different areas here. There's a humeral lesion, a very large lung lesion, adrenal gland metastases there. So we went for the combination again. In March 2020, develops a maculopapular rash. So this is certainly something that, could easily come through your door in in the community where a person on immunotherapy turns up with a rash. As we said before, fatigue and skin-related toxicities, rash, are the most common. So what would we do in that scenario? Generally, we think about a lanolin-based moisturizers, so cetamacrogol, with a corticosteroid cream. So we think either hydrocortisone initially, if it's mild, or Aristocort, triamcinolone, and then we might go to the stronger steroids. It's just those first two levels you can use more consistently for a longer period of time. If the rash becomes severe enough, we do think about a shorter course of oral prednisone, maybe not at the 1 milligram per kilogram, but at a lower dose. So we were managing his rash for quite some time, and then 18 months into treatment, he develops a worsening rash and also a very mild grade 1 pneumonitis. At that point, we stopped his pembrolizumab. And I should just say, for context, you're saying 18 months of treatment. The standard period of treatment that we think about is 24 months based on the early trials. So he was sort of 3/4 of the way through. We started him on oral prednisone, and then we repeated his PET scan. And what you can see here is that lung lesion is completely cold. It has no uptake. And in fact, he has no uptake anywhere. And so that's what we would call a complete metabolic response. So at that point, we're faced with a significant side effect in a gentleman who's had an excellent response to treatment. And at that point, we would pause the pembrolizumab thinking, well, actually, does he need to carry on? What did we do about his rash? Well, we sent him through to our dermatology colleagues, and the examination, they found small blisters. And so they arranged a biopsy and autoantibodies. And he was found to have bullous pemphigoid. And this is a classic, that's BP180. IgG is a classic anti-basement membrane antibody, and bullous pemphigoid. And this is, potentially you might see something relatively mild, which is what I think he had for quite some time, just not recognized by us. Something a little more significant there, and this grade 3, and then grade 4 is life-threatening. So fortunately, he wasn't in that situation, but he was certainly a grade 3, and it can look pretty innocuous. So what are we thinking about with the potential for rash? And I have this slide for two reasons. One is rash is quite common, so we have to think about all of these things. But it also just illustrates the timing that we might see when these side effects happen. Normally, I would say to people, the first cycle, you're very, very unlikely to get a side effect. So for most people, the first treatment, usually they don't feel any better or any worse. But very occasionally, we can see side effects. So they here have, in weeks 0 to 3, a psoriasiform rash. So particularly if someone has a background of psoriasis, we can certainly see that flare. More commonly, we get a maculopapular rash. Oftentimes, it's quite mild, but it can be more extensive, as we were saying before. That happens with the second or third treatment, so this 4 to 6 week period. Quite commonly, we can see a pruritus. We can see itch with no rash, and you might see their eosinophils go up in the blood counts. And that we might treat with, as you might expect, antihistamines, some moisturizing cream. That's usually enough for us to deal with that. Later on, you might get a lichenoid eruption. You can certainly see this. And then bullous pemphigoid can actually happen at any point down the track. Stevens-Johnson syndrome is rare. Dress syndrome and toxic epidermal necrolysis, these are all very rare, but they can happen at any point. And I think, the timing of these is indicative. It's not an absolute, but you can see how different things might occur at different times. And of course, we've spoken about vitiligo. Can't say I've seen too much alopecia, thankfully, but it's an autoimmune condition, so it certainly could happen. I'm sorry, this is a slightly small font here, but just, I thought it would be useful just to touch on the timing again. When might we expect these? And you can see here in the right-hand panel, we have weeks along the bottom, and the potential timing for when these side effects can happen. So adrenal insufficiency could happen anytime from 3 weeks all the way along to 1.5 years. Colitis can happen at any time. Diabetes, this is where we get this autoimmune destruction of islet cells. That could happen at any time. Hepatitis tends to be earlier on average, but you'll notice that most side effects are happening within the first 3 months, so the first 10 to 15 weeks, but there's a long tail, so they could happen at any point while that person's on treatment. And in fact, there is some evidence of people developing side effects even 3 or 6 months after treatment. What do we do? So almost no matter what you get, our first port of call is prednisone or IV methylprednisolone if the person's unwell enough to be in hospital. So although we're talking about lots and lots of complicated mechanisms, the treatment for most people that we'll see is prednisone. But it's reasonably high doses for a reasonably long amount of time. And so we then think about, okay, well, how do we manage this in an ongoing fashion? So, a classic example might be an inflammatory arthritis, small joint arthritis. Well, we might start with prednisone. Usually it's exquisitely sensitive to prednisone. So you might use 20 milligrams for a few days, then wean that down over the span of 3 weeks. But we might then introduce hydroxychloroquine as a steroid-sparing agent. So in this situation, we might just continue with hydroxychloroquine, bring the prednisone off, and continue with therapy for that person. Similarly, another example might be polymyalgia, especially if people have polymyalgia as a background, we can certainly flare that. And again, we would treat it prednisone, and then it would be a slow wean as we might do with a standard polymyalgia case that was happening outside the scenario of immunotherapy. So these are sort of typical side effects that we might see. We would think about prednisone as being our first course of action. And then if that wasn't responding, there are a number of other second-line agents, and they may change depending on exactly which side effect that person's having. Here's an example of how that might, bullous pemphigoid might occur. It might be that there are B cells with this autoantibody phenomenon that's happening, that's being controlled in this situation where you don't have any immunotherapy on board. So there's an inhibitory signal happening. As soon as we block that, you get B cell proliferation and more antibodies produced. And then there is another theory where you can get dysregulation through the germinal center and lymph nodes. So, there's some complexity in why they're happening, but our principle in terms of how we recognize them and what we treat is, we go back to that core idea. If they're developing new symptoms, we think about immune therapy. No one's going to criticize you for starting them on prednisone. Again, just thinking about, well, for different potential side effects, if we can't manage them well in the community, we get them into hospital and we think about second-line agents like mycophenolate, like tacrolimus, like they might use in a heart transplant or an organ transplant. We're thinking along the same lines there. I just want to make a plug for us throwing around prednisone willy-nilly. If there are complications, of course, for that. So we want to be sensitive to these potential ideas. And here's a lady that we had on one of our clinical trials who had a complication with pneumonitis for quite a long period of time with prednisone, and unfortunately developed avascular necrosis, leading to the need for a hip replacement. So, even our treatments for the side effects have side effects. So I think this is just acknowledging that we need to be judicious, thoughtful, and sometimes you can be trapped in this situation where the prednisone has long-term effects that we want to counteract. Just to touch on, I think, another particularly important topic in primary care is the chronicity of these side effects. So yes, let's say we cure the person of their stage 4 melanoma, everyone's feeling fantastic about that, but if they have an endocrinopathy, that's lifelong. So this is where there is an interaction that needs to happen between the specialists, in the hospital and our primary care colleagues who might then have the task of looking after this person's adrenal insufficiency into the future, or they're checking their thyroid dosing, or, one of these other potential side effects. And I think, here's as an example, a number of potential things and how many people are left with subacute or chronic toxicities. So certainly hepatitis can be slow to improve for some people. Diabetes, of course, there are people who develop type 1 diabetes or pancreatic insufficiency. So another gentleman in one of our clinical trials has this, so now he's on Creon. Arthritis can wax and wane. It generally improves over time, but there is, months and months potentially where these side effects can carry on. Generally, I would say to people, if they have mild side effects within the 3 months after treatment finishes, those should disappear. But there are some who are left with ongoing problems. What happened to our gentleman here? So he had the melanoma. He went on to methotrexate that controlled his bullous pemphigoid. And this is a scan at 5 years of follow-up. So he had 18 months of treatment, a further 5 years of follow-up. And he was left with this inactive lesion in his lung. And at that point, he'd had a sustained response, and we discharged him from further follow-up in December last year. So where does that leave us? I think early recognition of these side effects is the key. And the thing for us, and the core principle that I would work by is that it's our role to keep that patient safe. So we have to have we can be relaxed when they're doing well, but if they develop a new symptom, we have to have a low threshold for high vigilance, if you like. So thinking always, could this be something really important, or could there be something else going on? Is that fatigue actually a myositis rather than just I'm a bit achy? The interaction between the treating oncologist and the primary care physician is a key one, and I think only through clear and open communication can this work really well. Corticosteroids, as we're saying, mainstay for mild cases. Severe cases, those people really should be in hospital, involving multiple specialties and bringing in that expertise. As we're saying, any new symptom is an immune-related adverse event until proven otherwise. What happened to our gentleman, our first man from Iran? So he started like that, and after 5 years of follow-up, that's what he looked up. And his scan's completely clear. So his lungs now completely clear. He has no lump pushing his eye. His eye's working back to normal. And I think about 18 months ago, we discharged him from follow-up. So he's another gentleman who can live without that melanoma coming back. Here we go. Thank you all.
Thank you, Gareth. That was an excellent and very clear overview. Thank you for sort of hammering down those key points. It's always good when you lead a webinar with a clear idea of what to look out for. But it really highlights a few important points as primary care clinicians, that we really need to be making sure that we clearly put in patient classifications that patients have been on checkpoint inhibitors and that they are at risk of autoimmune sequelae, and making sure that that's at the top of the classifications in red highlighted, but also that the medications are appropriately listed, because of course they might not be translated through to our prescribing PMS software. Can we set off autoimmunity by giving vaccinations?
Great question. And I should have thought about this, as it is one that we talk about a lot. And in truth, for most vaccinations, the answer to that is no. There are some restricted vaccinations, and this came out of the early trials, the phase 1 trials, where patients, or at least one patient, had a live vaccine and then developed a myocarditis. Now, what that has meant is that the recommendation across the board over time has suggested that any live vaccine should not be given. So we tend to advise people to avoid MMR, yellow fever. I think rabies is a live vaccine. As I'm struggling to think of the top of I think it's H1N1 flu, chickenpox, typhoid. I think those are the common ones. The seasonal flu vaccine, COVID vaccine, shingles vaccine, those are all safe. We don't see any complications from those whatsoever. And all of those mRNA vaccines through COVID were all fine. Interesting, in fact, we've got a couple of trials at the moment using those mRNA vaccines, that technology, to direct people's immune system towards neoantigens. So we have some trials that are kind of adding this vaccination element to our immune checkpoints. So that's just a coincidental thing.
But the next question is, would pre-existing or previous myocarditis be a contraindication for therapy?
Yes, a great question. So does an underlying autoimmune disease, how do we judge those, and what do we do about them? So those, they're not absolute contraindications, actually. It depends a little bit on the severity and the activity. Roughly speaking, we think about an underlying autoimmune condition having a 50% chance of reigniting, if you like. Rheumatoid arthritis, Crohn's or inflammatory bowel disease, etc., etc. At times, though, we have to make that trade-off that, yes, you can cause a flare, but you might not have any other choice but to do that to treat the person's cancer. So we've had a number of people have flares that respond to their normal treatment, and they've responded in their cancer. So we don't think of it as an absolute. In fact, recently, even with people with transplant, we've started using checkpoint inhibitors with some case series coming out of the States and Europe, where I have a gentleman at the moment with a kidney transplant and a metastatic cutaneous squamous cancer. So we use pulse steroids around the time of his infusion, and we're giving him Keytruda, and he's responding to that and not rejecting his kidney. So we used to be very cautious about this, but we are being a bit more judicious now and spreading that with, I guess, some very, very close monitoring of those people. Myocarditis is that specific example. That's one that we would be very, very careful with, because um, the one side effect complication that we are most fearful of is a mixed myocarditis, myositis, myasthenia crossover syndrome. And it happens about 1 in 250 people. But if you get it, we have had a couple of people around the country pass away with that. It's not, other people have been well treated and have recovered, but it is one that we take seriously. So myocarditis is a particular hook, but other ones we are much more open to that.
So the next question is, can you please tell us about Padcev side effects when combined with Keytruda?
So that's an antibody drug conjugate, right? So this is an ADC. I have to say, with bladder cancer, I don't treat it. The ADCs, the principle there is, I'm sure you're maybe aware of this, but there's a targeted monoclonal antibody that is linked then to a chemotherapy molecule that's meant to target the tumor and deliver the chemotherapy directly into that tumor. So to reduce the chemotherapy side effects. Generally, we think of the side effects with ADCs, but please take, the big caveat that I don't work with this particular one, but we think about them delivering the same types of side effects that chemotherapies would. So lowers blood counts, mucositis, diarrhea. Specifically, the interaction between chemotherapies in general and ADCs and immunotherapy, their side effects tend to be additive rather than synergistic. So we don't tend to see side effect crossover or amplification when they're used. In fact, if anything, if you combine a chemotherapy, which we do standardly with immunotherapy for, say, lung cancer, you might get slightly less autoimmunity while they're on the combination. So I haven't fully answered your question. That those ADCs are much more specific around their individual side effects. I just don't use that one. So apologies for giving you a generic answer.
So we were discussing briefly before the talk about monitoring in primary care, whether we should be calling these patients back for annual thyroid function, liver function, HbA1c going forward. Could you just talk to that for a moment?
Sure. So, I think, what do we do when they're on treatment? That's the first thing. So these treatments are either delivered 3 weekly initially, then moving to 6 weekly or 4 weekly. So there's this sort of cyclical pattern as we have with most of our treatments. And we're doing blood tests every 3 weeks for those people. Yeah. And we sort of alternate between full blood count, LFTs, urAEs, and then the subsequent cycle would include thyroid function, fasting glucose, and a cortisol, looking for those endocrinopathies. I think if they have no toxicity, or ongoing toxicity, the risk of delayed immune side effects is something in the 2 to 3% range. So there isn't a huge risk to them of developing an endocrinopathy down the track. I don't think I've ever seen one. I've seen 2 particular side effects, colitis and nephritis, in the 3 to 6 months afterwards. Again, it's rare. I'm not sure that routine screening necessarily is very beneficial. It would just be, if the person turned up with something, to be thinking, oh, this person was on immune therapy, I need to think of an immune-related toxicity. Of course, the exception to that, I think, is the endocrinopathies. That those are generally lifelong, and once we're seeing them only every few months, the responsibility does sort of fall back on the primary care physician, especially when we suddenly discharge them, and then it's like, we wash our hands of everyone and rely on you guys.
Are there any go-to guidelines, the ESMO guidelines that you referred to?
Yeah,
Your go-to?
Yeah, the ESMO guidelines were very, they're detailed, right? So they're talking at multiple different levels of intensity. So once you're getting to a grade 4 side effect, that's something that's going to be in hospital, et cetera, et cetera. But they are, I think, New Zealand appropriate. I think they're very balanced, and they give very quite clear thoughts. If someone turns up with a hepatitis, okay, well, we need to think about doing these tests and this type of treatment. You could use those and be very safe as the first line. If you're, I don't know, trapped on a desert island with someone on immunotherapy, that'd be a good fallback option.
So thank you again, Gareth, for taking the time to present this evening after a busy day. And thank you for everyone for joining us tonight. Ka kite.